Hello, everyone. My name is Breana Hill. I am currently a third-year OBGYN resident at the University of Colorado, and I am presenting our poster entitled, Does Lymph Node Dissection Impact Adjuvant Treatment or Survival Outcomes in High-Risk Endometrial Cancers? And I'll be presenting on the behalf of all my co-authors who are listed here. As part of our background, we do know a few things. We know that lymphadenectomy does not improve overall survival outcomes in patients with type 1 low-risk endometrial cancers. We also do know that sentinel node mapping has a high detection rate and accuracy in uterine cancers. But what we sought to find is that what we have low understanding of is prognostic and adjuvant treatment implications of sentinel lymph nodes, which have not been well explored in high-risk endometrial cancers. Our objectives were to evaluate two things: one, the overall survival, and two, the adjuvant therapies received by patients undergoing complete versus sentinel lymph node dissection for a diagnosis of grade 3 endometrioid or high-grade non-endometrioid endometrial cancers. This was a retrospective chart review performed at one institution of the University of Colorado over a 10-year study period. We reviewed charts for patient and disease characteristics, including those listed here. We also excluded those patients who received neoadjuvant therapy and had debulking of only grossly abnormal lymph nodes. After we met our exclusionary criteria, we identified 153 patients that met the inclusionary criteria that all had either a diagnosis of grade 3 endometrioid, serous, clear cell, carcinosarcoma, or mixed high-grade on final pathology. As we can see here, going through the tables, we identified 111 patients that received a complete lymph node dissection. We identified 26 patients who received a sentinel lymph node dissection and 16 patients who received no nodal assessment at all. This table here shows that there was no significant difference across the histotypes amongst the three groups. And then moving on to this table here, this does show a significant difference in their route of surgery. Those who received a complete lymph node dissection were more likely to have an open surgery. Now, looking at these two tables here, which identify our two objectives, the first one being the adjuvant therapy received by each nodal group. We divided the adjuvant therapy groups into surgery alone, chemotherapy alone, chemotherapy with radiation therapy, extended beam radiation therapy with vaginal brachytherapy, and then the final group, extended beam radiation therapy alone. And what we can see here is that there was a significant difference between the three groups in regards to what type of adjuvant therapy was received. The biggest one being, we can see here that those who had no nodal assessment were more likely to have surgery alone. And then we can also see here comparing those who received a complete nodal dissection to those who received sentinel node dissection, that those with complete nodal dissection were more likely to receive extended beam radiation therapy and vaginal brachytherapy. Moving on down to our fourth and final table, which depicts cancer recurrence and death from cancer, we can see in the right-hand column here that there was no difference across the three groups in regards to either of those items. Our conclusions, although limited by sample size and retrospective nature, were that one, adjuvant therapy choices were significantly different across the three nodal assessment groups, and two, that recurrence-free survival and cancer-specific overall survival were not significantly different across the three nodal assessment groups. While we recognize that our conclusions are limited by the sample size and retrospective nature, we do hope that our results are hypothesis generating and will prompt consideration of non-inferiority trials to better serve our patients. Thank you everyone for your time. I hope you enjoyed this presentation and enjoyed the rest of the conference, and hopefully get to see everyone in person next year.